Thank you so much, sir. Thank you very much. First of all, I would like to thank Dr. Manoj Chawla, Purvi, Dr. Bansi Saban, and entire DRS organizing committee to ask me to speak here. It's a very difficult time, a post-lunch session. I'll try to keep it interesting so that you don't fall asleep. And deliberately, I've told the organizers to keep the lights on. So anyhow, so I'll talk on automated insulin delivery systems, how they're doing it. So this is my disclosure. Now coming to AID. So when I say AID or automated insulin delivery system, it has basically three parts. You have a device, which is an insulin pump. Then you have a glucose sensor, or you can call it continuous glucose monitoring. And then you need the brain algorithm. So in this system, most of the systems have the brain inside the device itself. But nowadays you have systems where the brain is actually in the mobile app. But most of the systems which are available in the world, they are mostly the algorithm of the brain is basically inside the device itself. Now this is how it looks like if it is a wired insulin pump. So you have a sensor, transmitter, glucose sensor, and infusion site, and the pump. So what happens? First, the glucose sensor is measured from the subcutaneous tissue by the sensor. Through the transmitter, it is transmitted to the device. So this basically works as a data for the algorithm to work. So depending on the sensor glucose data, the algorithm then does all the khichdi and whatever data it has based on the. So in this system, the system which is there in India, it is PID, a proportional integral derivative with insulin feedback. There are other type of algorithm also, MPC and physiologic, but most widely used is PID because this is a very old age algorithm used in the space industry, airline, and the most common is your heating, cooling industry. And then this pump algorithm will tell how much insulin to be delivered to this person, depending on the sensor glucose value. If the glucose are high, the insulin delivery will be more. If the glucose is low or normal, it will be slow. Sometimes it can be stopped also, but it happens automatically. So this is how a AID system works. Now this is a healthy pancreas. If you see, in those who are non-diabetic, in a healthy person, depending on the glucose, our pancreas secretes first phase, second phase. All of us know that. Same, just similarly, the automated insulin delivery system, depending on the target. So you can set a target of 100, 110, 120. In some pumps, it can be 150. Depending on that target, there is automatic basal, and if required, there is automated small correction boluses also delivered to the individual to keep the glucose at 100, not more, not less. It's easy to say, but then that's how the algorithm works. So this is the automated background insulin which keeps on happening. So adaptation is very, very important in an AID system. And so then you will ask me, if the algorithm does everything, what's the role of you and me as a physician? So the algorithm will do, depending on the sensor glucose value, it will automatically deliver basal, correction boluses, and also it will detect calculate the insulin sensitivity factor. As a clinician, you and me have to decide what should be the target for that particular type 1 or whatever type of patient we serve. Then what should be the active insulin time in that device and the carb ratio. So that we have to keep on. So these are only three things we have in our hand to titrate, do the permutation combinations. Rest all will be done by the algorithm. And in India, we have only one system, which is AID, that is 780G from Medtronic. There are others like Control IQ from Tandem. There are, you have Omnipod, but they're all available in the developed markets. In India, none of them are there. And if you see 780G, there are currently, at present, 210 scientific publications in peer-reviewed journals. Now, why should AID be standard of care especially for a type 1? You have option of MDI with BGM. You can use MDI with CGM. You can use a pump separately and a BGM separately. You can use separately a pump and a CGM, or you can combine and make AID. Because if you see the data, this is a real world observation study from Steno Diabetes Center, Copenhagen, very, very well known center for research in diabetes, especially type 1. Now, if you see this study, it very well shown, if you take MDI with BGM, MDI with CGM, and AID, you get the best control time in range with AID. At the same time, it is giving the best control time in range without increasing time below range, means without hypoglycemia. That we know. If you give insulin, you will get a good A1C, but you will also get a lot of hypos. But here you get a good control without hypoglycemia. So that's why AID is currently the standard of care for any type 1. And as I said, there are other systems in the world. You have Control IQ, Omnipod, iLet, CAMP-APS. India has only 780G. And you can see even if you compare, this is the data that this has the robust algorithm in terms of giving you the best time in range as compared to the other systems. Not only glycemic outcomes, the user also get beyond glycemic control, because he or she has to live every day, every moment. Whether she's going to play badminton or during her, if she's a young female, menstrual cycle, so many things. So you can see the baseline things, and you can see the quality of life in terms of, if you use AID, it's much better if you live in and out every day type 1 diabetes. And these are the global guidelines for AID, whether it's ADA, ATTD, NICE. You can see the grade A recommendations. AID should be preferred insulin delivery device for any type 1. ATTD also says same thing. All of you are aware, NICE did a research in 2023 November, and they are now giving free of cost, because it's NHS, to every type 1 AID system. That's the data they have globally. Same for ISPAD and JDS. Now, this is real world data. This is not a clinical trial. Almost 4 lakh type 1 people, mostly type 1, 95% are type 1, because the system is only approved in type 1 that time. And you can see the time in range. Time in tight range, 47% overall. Time in range, 72%. And if you see the time below range, 1.4, 0.3. And if you use the recommended settings, which they say 100 milligram per deciliter target and 2 hours AIT, you get time in range 77.6 and 52% time in tight range. And if you see, you are not increasing time below range. Hypoglycemia is same, but you're still giving a better time in range. So these are patients. This is not a real world. This is real world data, not a trial. Now, how do you see individual country? Now, if it is Italy or Netherlands or Great Britain, or you can see India, the time in range achieved by people with type 1 is almost same, and the same hypoglycemia, much less, if you compare India to any other developed nations. And if you want to see Asia Pacific, Hong Kong, India, Japan, Korea, Taiwan, Australia, New Zealand, almost similar, except Hong Kong has a much better time in range. Otherwise, most of them are in the same range. And if you use in the optimal settings, you can see again, almost same time in range and GMI in all the groups. So it does not discriminate whether you are from Netherlands or UK or US or India. You give the best. So when we launched this device 3 years back in India and Southeast Asia, we thought we have very high carb content. It might not work as it works in Europe, but it wonderfully works even in India and even in Singapore, Malaysia, or any of these countries who eat a lot of rice like us. This is to show this real world how flexible it is. If it's a child, you have school days, you have holidays, you have week and weekends. It adapts very well. You can see the time in range, time below range. It adapts very, very beautifully within these weekends, school vacation. And the best part is the algorithm updates every midnight, the settings. Depending on the feedback for the last 24 hours and for last 1 week, it automatically sets change. This is during Ramadan. Again, it mentions time in normal glycemia, TING, T-I-N-G. So this is a new term for TITR, time in tight range, that is 70 to 140. So they have not decided whether to call it TING, T-I-N-G, or time in tight range. You can see in Ramadan also, before Ramadan, end of Ramadan, you can see the AID system or AHCL giving you much better time in range and time in tight range as compared to MDI or sensor augmented pump therapy. Very, very flexible. This is not published yet in LADA patients. Same data you can see. Almost 78% time in range. Again, this is not published, data from Italy. People on diabetes with dialysis. They could not achieve 70% time in range, but close to that, 68.41% without any hypoglycemia. Again, people who have renal compromised. These are all end-stage renal disease patients or on dialysis. Now, questions sometimes come, the pediatricians or pediatric endocrinologists ask, how soon can we start this? If you have a child of 1 year or 2 years, how soon you should start? The data shows if you start the earliest, you can see the green, AID start from 0 to 6 months of diagnosis, they get the best outcome in terms of A1C and less decay and less hypoglycemias as compared to children who have started later on between 6 to 12 or after 12 months of diagnosis. So once you think that the child and the parents can handle that, it's the best time. So this system can handle any normal challenge to glycemic equilibrium, whether it is during stress, you are not well, sickness, you went to a party, you are playing, or in your fun times. It will definitely, it will adapt automatically to give you the best control. The best part is without causing hypoglycemia, because that is very important. And this system was only approved for type 1 above 7 years. Recently, just a couple of weeks back, it got approval for 2 years and older during pregnancy and also type 2 insulin requiring people. Although off-label these were being used, but officially this just recently got CE mark. In India, still it is off-label these conditions. But I know from my knowledge that at least in India, out of 2,000, 2,500 patients who are on 780G, close to 20% are type 2. This is type 2 data, that all the previous data we saw that was type 1, and you can see the type 2 data, baseline and end of study. You can see the time in tight range and time in range. Wonderful, no hypoglycemia at all. This was again self-reported, people who used more than 100 and less than 100. Again, data. It works very well, people who used more amount of insulin. And then we all know people type 2, they use GLP-1 RA. So there was a clinical trial where they used the system in type 2 along with GLP-1 RA. And you can see people who used with GLP-1 RA actually had a better time in range as compared to people who did not use, especially in this type 2 category patients, because anyhow, type 1 people don't use GLP-1. So it's wonderfully, it is synergistic to GLP-1 RA. This is a 2 to 6 year old, small, very, very small kids, very, very vulnerable, variability is too high. You can see the system did not do the best as an adult or adolescent, but not bad. Almost you can see 68% time in range and 47.8 time in tight range. Not bad. This is Lenny study, and this is another study in 2 to 6 year old, but a long-term follow-up up to 18 months. And you can see again, they did not achieve a time in range of 70%, which is required, but I think any of the ped endos who handle such small children, they'll be very, very happy with the time in range of 67% of time in range and very less time below range. This is in pregnancy, very, very well-known crystal study, and they assessed intrapartum and postpartum, and again, you can see the time in range and time below range, well within the range. Yeah, I'll quickly. So earlier we used to read when I did my master's or bachelor's that person should know carb counting, they should know tech savvy, they should be educated, everything. But nowadays, with the AID system, it can be used across ages, across geographies, any background, knowledgeable, not knowledgeable, educated, uneducated, behaviors, whether carb counting is known or not, at diagnosis. So you can use it any type of patients. And studies have shown if you're tech naive, you get actually better results, because if you're techie, you play around with the algorithm. So this is just a case study I've taken, not from me, this is my physician friend from Dubai. And you can see this is a 47-year-old gentleman, type 2 long-standing, A1C 14%, on MDI with hyperlipidemia. With MDI and CGM, you can see the time in range. Pathetic. is the word for this, with 14% A1C. And it was started, and you can see initial after a few months, it was 57% time in range, then improved to nice, and then it went up to almost 90% without any time below range. So goal of technology should help people with diabetes to live normal life, and that is what this system does, help stabilize glucose values with very, very less hypoglycemia and variability, automatically adjust and automatically delivers the insulin. Take home message, hyperglycemia is the primary cause of long-term and short-term complications, and AID is currently the best option for people with insulin-dependent diabetes, whether it is type 1, type 2, gestational, LADA, or anything else. Thank you very much.